Hello, and thank you for the invitation to be speaking today. It's good to be with you all, and I'm going to spend the next 10 minutes reflecting on some of the implications of comorbidities in HIV for patients. So we know, of course, one of the biggest drivers of the rising prevalence of comorbidities is aging. We know particularly from data in Europe that infection-unrelated malignancies are increasing rapidly. Increase in death for non-AIDS cancers is increasing. We've got rising numbers of comorbidities, with the over 50s, about 61% having 2 comorbidities, and some prediction data from a Dutch cohort that there'll be 3 or more comorbidities by 2030. We know there's higher cardiovascular disease incidence compared to the general population. And interestingly, all of this greater experience of living with comorbidity in HIV is raising a number of specific concerns. And there was some nice data from older people living with HIV in the UK, showing great concerns that actually when you move beyond your HIV specialty to being in cardiology, neurology, oncology, that actually what are going to be the HIV skills and understanding of other clinicians that you might work with, how well might care be coordinated, and what might be some of the issues around confidentiality, of course, which have always been so important for people living with HIV navigating the health system. I'd like to share this data with you from some work led by Public Health England and NHS England that I've been involved in, looking at mortality. So death among people living with HIV began as a London-based project. This data has now been published, and now the project is being rolled out nationally, but it's very interesting to see what are people dying of with their HIV. So we can see a number of non-communicable diseases. So we can see malignancies, we can see liver disease, cardiovascular disease, stroke and respiratory disease are now causes of death increasingly among people living with HIV. Of course, each of which brings their own challenges, symptom profile. These are progressive conditions, they're not reversible. So we need to be thinking about care for people living with HIV and comorbid disease. And of course, what we really need to be thinking about is person-centered care, where we work at the interaction of physical problems, so pain and symptoms, social problems, psychological and emotional problems, and spiritual problems, and operating at the interface of those. And as my colleague Carla Alexander from the Institute of Human Virology in Baltimore says, we need to focus from the life of the virus to the life of the host. And of course, taking a really patient-focused approach to management of these conditions with people living with HIV requires taking a very patient-focused and a patient-reported outcome approach to the management of these conditions to make sure that our care is good quality and appropriate. So it's very interesting to think about what might be an important outcome. So what matters when we've got increasing comorbidity among people living with HIV. So some work we've been doing to develop outcome measurement with people with HIV, we did the qualitative work to develop face and content, validity of the measure. So what's an important outcome? What matters to you? So this person living with HIV said, I'd like to hear them say, how's your physical health? How's your weight? How's your mobility? Is there anything going on there? We compare that to the commissioner who says, and a commissioner is a specific role in the health system who purchases and decides which services are available and are funded within the health system. And a commissioner of HIV services said they want to focus on adherence, they want to focus on blood results, and they want to focus on partner notification. So that's a very, very different focus. So if we take a simple example, all the conditions that all the comorbidities I showed earlier, of which people living with HIV are dying, one of the most common symptoms is pain across those conditions. We did a systematic review with Katrine Moons, which showed that pain is one of the most common symptoms across those conditions. We can see from Caroline Sabin's cohort study that around 70% of people, older people living with HIV, have had pain in the last month. And of those with pain, they're missing days of work, they're missing study due to their pain, and they are seeing doctors about their pain, but clearly that pain is persisting. and they have more depressive symptoms, poorer quality of life, which is really crucial here, and greater functional impairment. So it's a really high prevalence problem, and it's a common problem across the comorbidities. So we need to think about how that's managed. So then in a further study, and this was recently published in AIDS Care, we asked people living with HIV and living with chronic pain about their pain management approaches. So this black heterosexual man living with chronic pain and HIV said, when you tell the nurse or whatever that you have HIV, they give you a dirty look. I'm honest with you, sorry, but this is the truth. So when people presenting with HIV and pain are presenting beyond their HIV traditional services, there are clearly issues around stigma. Or GPs who don't have the time, this woman said, you should sit, they tell them you should see your consultant because it's your HIV. They don't look deeper. So this is the problem that we're seeing commonly, that if you present with a symptom, then it's always seen through the lens of the HIV and not any other comorbid condition. So there are very interesting questions about how patients may navigate the pathway. And a further patient said the HIV consultants are pressurized into just doing HIV. They can't look at this for you. You have to go and talk to another clinic. So I think there are major questions about how people navigate care when they're presenting with symptoms that may be caused by other comorbid conditions. And then, of course, there's the challenges of living with comorbid conditions. So another study we've conducted in the UK, it's now been published. We interviewed people living with HIV and other progressive conditions. So this man is 52 with HIV and COPD. The problem is now him navigating the system. If he has an unplanned admission, this man is trying to explain how difficult it is when an ambulance arrives, takes you to a hospital which is not your usual one, and you're trying to go back through 20 or 30 years of history. You can't get your breath, you're trying to explain. So it becomes very, very complicated when you're being admitted to different places where they don't have your history. And then, of course, just simply navigating information. People with HIV traditionally are perceived as being quite good at understanding their condition relative to other patient populations. But now this gay man has got HIV and prostate cancer, and he's finding it difficult to know what's out there, what's going on. How do you ask the right questions? Spending a long time trying to work out what's good for him. So I think this whole idea of trying to navigate information and decision-making is complex. So this really brings us back to the idea of person-centered care. So we're both focusing on the individual and not the disease. So really trying to deliver care which is safe, effective, patient-centered, efficient, timely, and equitable. So that's the core of patient-centered care. But for some work that Mary Boa-Fay has been doing, we know that people living with HIV describe frustration because of problems with continuity of care, with staff changes which undermine relationship building and discourage disclosure of their concerns. So there are major issues at the patient, clinician and patient health service interface that we need to consider. So we can conclude that as patients present and people living with HIV present with more comorbidities, multimorbidities, attention to the physical, psychological, social and spiritual concerns that they have is going to be absolutely crucial for optimal patient well-being. And of course, we need to be aware, I showed you that mortality data, that increasing comorbidity and aging brings greater clinical uncertainty, and there is much more scope for the importance of decision-making, particularly when people are living with life-limiting progressive comorbidities. So people with multimorbidities, of course, require disease management. That's not the question. The question is how we also focus on patient-reported outcomes. And I would point you to an editorial I did on patients with progressive conditions and HIV in the Lancet a few years ago, playing out some of these debates. This is happening. So I'm pleased to say that the British HIV Association developed new standards of care with community. So people living with HIV are at the core of the development of these standards, endorsed by all of our royal health colleges, and person-centered care is a standard of care now, particularly in relation to comorbidities and aging. And I would also draw your attention to Hawley's bow tie model, which I think is very helpful when we're looking at people with comorbidities, many of which are progressive. So how we focus on cure and control, but increasingly we need to integrate supportive care and there may be survivorship, there may be rehabilitation, there may be end-of-life care, and there may be bereavement issues, but we need to think about this more now, because good quality care is from diagnosis to the end of life. The last big question, of course, if we're going to take a patient-centered approach, and we're looking at comorbid disease and HIV, is delivery models. I think probably realistically we can't make a request for greater differentiation of cardiology, oncology, neurology clinics for people living with HIV. I wonder where the resource barriers might be to that, and what are the questions for integration. We saw in the data that patients were concerned around potential stigma, communication, information sharing. So I think the questions about how we deliver these models are important, although I would note that with Jaime Vera and Catherine Bristow here in the UK, we have a study at the moment, the Silver Clinic, when we're looking at how to model old age care and HIV care in joint clinics with gerontology and HIV medicine, and how we may develop such models and how feasible and acceptable they might be. So thank you very much. It's great to be with you today.